case that we have is a 58-year-old female with a history of rheumatoid arthritis, but she also had superimposed psoriatic arthritis and demonstrated large psoriatic plaque formation on the dorsum of both feet. She had very significantly painful plantar callosities under the forefoot, so she walked primarily on her heels. She was very limited in her ambulation. She had rheumatoid foot, hand, and wrist involvement. This is kind of very rare in this era where we have biologics now that have eliminated a lot of these severe deformities. So on my physical exam, she had good pulses. Neurologically, as rheumatoids can have signs of neuropathy and even loss of protective sensation, but in her case, she had full sensation. Dermatologically, as we'll see, she had these large psoriatic plaques on the dorsal aspects of both feet, and then complete subluxation and dislocation of the metatarsal phalangeal joints. And as I stated, very antalgically, and actually had large heel tylomas due to the fact that her weight bearing was transferred to her plantar heel. This is a look at the foot. You can see dorsally the large psoriatic plaque, and this will create an issue from a surgical standpoint because these particular plaques carry a lot of bacteria, have high risk of infection, and also Kebner phenomena can occur as a result of trauma in these areas. You see the severe hammer toe deformities and the plantar callosities and the dislocations of the metatarsal heads. Also, you can see a large lesion over a styloid process as she had been walking antalgically. This is a look at a radiograph. You can see severe osteopenia throughout the foot, severe rheumatoid forefoot involvement, relative lack of involvement in the rest of the foot, but complete dislocations of the lesser metatarsal phalangeal joints. You also see, interestingly, the proximal phalanx of the hallux, which is very, very hypoplastic. She was a juvenile rheumatoid arthritic, and as a result of her JRA, the inflammatory disease actually caused a premature closure of her growth plate and led to this very atrophic form of hallux. She had never had any particular surgery. You can see her rear foot and midfoot are pretty well aligned, all her deformities at the metatarsal phalangeal joint level. So the proposed procedures in this situation would be to approach the metatarsal heads plantarly to avoid the psoriatic plaque. This was described by Hoffman, and also to include a first metatarsal phalangeal joint arthrodesis. Here you can see I did use a dorsal incision over the first metatarsal phalangeal joint because it was clear of the psoriatic plaques. And then this is the Hoffman incision, which can be modified to a Fowler approach if you want to ellipse this area. But in this particular case, a single incision was utilized. Here's the dissection. The dissection begins transversely through the subcutaneous tissue, and then all your dissection becomes longitudinal at the metatarsal phalangeal joint level. And obviously, as you can see, these metatarsal heads are lying directly, practically under the skin. There you see the subcutaneous tissue proximally. When you resect these from a plantar approach, it's a little bit more difficult because of the fact that there's declination of the metatarsal. So you have to make sure when you do cut the metatarsal heads to pry it plantarly and get on top of it rather than try to do the osteotomy
Dr. John?
From plantar to dorsal. Yes.
I'm sorry for the inconvenience. Yes, I could able to see only the first slide, doctor.
I don't know why. We've got ours on.
Okay, could you please share your screen again and try?
Okay, we'll try it again.
Sure.
Can you see it now?
Yes, it's in the first slide, the title slide. Yes, it's going up. Okay.
Well, do you see these?
Case study 1, yes.
Can you see those?
Yes, doctor. I guess it's an 8th slide.
Okay, so you see these slides now?
Yes, I could able to see the slides now.
Okay, so do you want me to start over, or how do you want?
You can
Or
you
just
can
continue
continue.
from here?
You can continue,
Okay.
doctor. Okay.
Okay, so this is the approach here through this Hoffman approach. As I stated, the metatarsal head resection should be from dorsal to plantar, not plantar to dorsal, because of the declination here. And this gives you very, very good exposure for resection, and you don't have to deal with the dislocated proximal phalanx here. The other thing that I like to do in these situations, rather than actually do incisions on the digits themselves, due to the degree of osteoporosis, you can do what we call a manual osteoclasis, which is basically where we literally dislocate manually. And in some instances, there's a fracture occurs to the neck of the proximal phalanx to align the toe very nicely in these situations. And it works out very well and gets the deformity corrected without ancillary incisions. Here you can see the first metatarsal phalangeal joint arthrodesis that occurs here. In this particular case, we don't use a cup and cone because of the severe osteopenia. We do a planal resection in this particular case, mostly on the metatarsal head side because she has a very little proximal phalanx left, as I had explained before from her JRA. I like to use a 0.062-inch K-wire for my alignment. That way I can get the toe exactly where I want it and line it in the sagittal, frontal, and transverse planes. And in this particular case, I did go ahead and use a compression screw with a dorsal locking plate in this case. And I did use a locking plate here because of the degree of osteopenia. Here you see the resection of the metatarsal heads and the good alignment of the remaining digits. Here you see the closure. As I stated, in some instances, you can take an excision of some skin, the so-called Fowler approach, and this will actually bring fat pad more proximal up over the remaining stumps of the metatarsal heads. But you do want to make sure that you've resected enough of the metatarsals that they're not prominent in any way plantarly. The second case is a 64-year-old male with a history of RA and had long-term disease and had never been controlled. Again, you don't see many of these patients in the United States anymore because of the biologics that are utilized that are extremely effective in controlling this disease. He was referred to rheumatology, who put him on high doses of prednisone, a biologic response modifier, Enbrel, and this was able to control his active synovitis. This is what he looked like prior to being sent to rheumatology. Extremely severe rheumatoid pannus and synovitis involving the entire ankle, the subtalar joint. You can see he has a dislocation of his talonavicular joint as a result of this pannus, which destroys the supporting structures of the subtalar joint, the interosseous talocalcaneal, the cervical ligament, and the spring ligament. And obviously has a very severe deformity here where he's walking on the talus. Once rheumatology basically cooled the synovitis, got the synovitis under control, the approach was then to do a double arthrodesis. I like to do these in severe valgus feet from the medial side to avoid lateral incisions, because when the deformity is corrected, it obviously gaps your incision, leads to a high incidence of wound dehiscence. Also, angiosome areas on the lateral side of the foot are really deficient only with the peroneal artery. So in this particular instance, you follow the tibialis posterior in, identify the talonavicular joint, expose it usually with a Hintermann retractor, prepare the joint, and then you obviously are looking directly into the anterior middle facet under the neck of the talus, get the distractor there at the sustentaculum in the neck, and you're able to pry the subtalar joint and expose the back portion of the posterior facet and prepare that properly. And here in these instances, in severe osteopenia, I like to use fully threaded and solid screws, not cannulated screws in these particular situations, because much greater hold and much ability to hold the compression that I want. And again, you have to be really careful about over compressing these, and you have to disperse your screws in parallel fashion so you don't get too much compression. As you'll see, I have a case that was sent where this was a patient that in osteopenic bone ended up with severe overcompression. This is the third case of a 62-year-old African American female who presented with a prior history of having undergone a triple arthrodesis for post-traumatic osteoarthritis. The patient said that her foot looked well initially, but then about 6 months later, she noted that her foot began to collapse. She did have a history of rheumatoid arthritis, and the initial surgeon failed to recognize that this was part of the deformity. She had a very intelligent gait. She was walking in a rocker bottom on her plantar midfoot. She was in an accommodative shoe wear, but was very limited in her ambulatory ability. Physical exam noted good pulses. Neurologically, again, she noted good sensation. In these cases, some of them can demonstrate neuropathy, and certainly I've had rheumatoids who have actually Charcot deformities, but this was not the case in this situation. This is a very rigid deformity, rocker bottom, and we'll show you the x-rays here soon. Here you see the x-ray on the lateral view, which is the most demonstrative view, and there's a few issues here. As you can see, the screws are basically so-called piled up across the midfoot, the talonavicular and calcaneocuboid joint, and you can see there's severe osteopenia, which was related to a rheumatoid disease. Also, at the time that this triple was performed, there was no Achilles tendon lengthening. And in any of these midfoot issues, especially flat feet, you have to be aware of Aquinas forces. They are very significant, and if they're not addressed, they can contribute to failure of your procedure. As you can see, with all the hardware piled in this osteopenic bone, you get accretion of bone, and obviously, with the rocker bottom, ended up with the tight Achilles tendon, and led to a rocker bottom deformity. So in this case, basically all the hardware had to be removed in this situation, and obviously a direct Achilles tendon lengthening was performed in this situation. I did do it percutaneously. Most of the time you can get the length you need through a percutaneous approach. I did a 2-incisional approach to obviously remove the hardware, and then I used a plantar midfoot wedge across the midfoot to plantar flex the midfoot in this situation. So I was able to recreate the longitudinal arch of the foot, as can be seen. In this particular instance, just solid beaming screws were all that were needed. Again, you do not need tremendous amounts of fixation in these osteopenic patients in these particular cases. And in this case, you can see we did get a very good reduction of her deformity, and the patient became very nicely ambulatory in this situation. The fourth case is a 75-year-old Caucasian male who had a history of RA, presented to the office with a painful flat foot involving his left foot. He did have it on the opposite right foot, but not as severe. He said he was flat-footed most all of his life, but the rheumatoid disease came on in around his 50s. He was fairly well controlled with that, but he did say he had bouts of significant synovitis in both feet periodically through his 60s. And he noticed then over time that his foot began to become a little bit flatter as a result of this. He basically then had an instance where his foot became extremely painful, and all attempts at trying to reduce his discomfort with immobilization, cortisone injections, and medications such as NSAIDs were completely ineffective in this particular situation. So his exam is pretty much all normal also in this case. Interesting, we'll talk a little bit about the biomechanics of this foot. He had this large tyloma over the talar head, but you can see the talar head is medial, not weight bearing. And you'll see on the radiographs, he did demonstrate a complete subtalar joint or a talonavicular dislocation, very similar to that prior case, but in this situation, not associated with such intense synovitis. Here's the look of his foot. Again, you see this tyloma over the medial side of his foot here, and it's obviously not in a weight-bearing area. It's not associated with a rocker bottom. In fact, if you look at his foot, it looks pretty much normal. It looks like he has a nice longitudinal arch. If you take a look at his from the DP view, you can see that the forefoot is well aligned. So you look at this foot and say, geez, what the heck is going on over there? And then you go ahead and take an x-ray. Here you go. And this is what he has. And you can see as a complete talonavicular dislocation. You see the subluxation of the talus on the posterior facet of the calcaneus in this situation. So what happened is his rheumatoid disease destroyed the supporting structures of the subtalar joint. The interosseous talocalcaneal ligament, the cervical ligament, and the spring ligament were completely damaged by the disease. And so then the talus became almost like a loose tooth and began to drift forward and medial in a rotatory manner. When this actually happens, the navicular does not pivot laterally. And as a result, the forefoot, and if you look at his cuboid abduction angle, all stays normal. And this counts for the fact that you have a very severe deformity here, yet the patient clinically doesn't demonstrate significant deformity clinically. So in this case, when I opened up the talonavicular joint, you can see the degree of disease to the head of the talus. But when you put a laminar spreader in, the talus just immediately pushed back into its corrected position, almost like a loose tooth and reducing a loose tooth. This patient was relatively obese, not very active. So in this particular instance, I just felt a localized talonavicular arthrodesis would be adequate for him. Certainly we could make the case for adding the subtalar joint in this situation, but in this case, I decided to do an isolated procedure with him. And here you can see we use a 3-screw effect. And interesting, you see now how that posterior facet is completely reduced in the subtalar joint as a result of the supporting structures in this particular case being completely deficient. Also in this, I do like to include the anterior and middle facet of the subtalar joint, and I feel that's an adequate reduction and correction without necessarily including the posterior facet, but you certainly could make the case for having done that in this particular situation. I'd like to thank you. Sorry for a little bit of the AV issues early on, and thank you very much for the invitation.
Thank you, Dr. John. Thank you for sharing us your presentation. If there are any questions with regards to this presentation, you can ask him now.